Hello, friends. Today I have come with a simple topic, but it's a very important topic. It's a pure theory topic, but very, very important for both undergraduates, postgraduates, as well as practicing obstetricians. That is high risk pregnancy. How do we recognize that? How do we pick it up? And how do we refer this patient for a safe confinement? So let's straight away go to the topic today because there are lots of things to be covered in this particular topic. Before we dwell on high risk pregnancy, we need to know what is antenatal screening. Now, why screen at all in the first place? Antenatal screening is an example of preventive health care at its best. WHO always says now health is not just uh, prevention, but it is also promotion. So we prevent as well as promote a healthy lifestyle for all pregnant women so that there won't be any complications later in the pregnancy. The aim is to help, obviously, and to educate the mother to achieve optimum health so that the outcome of pregnancy and childbirth is favorable for both the mother and her baby. From a cost benefit standpoint, also, prenatal screening and care has proved effective at lowering maternal and fetal or neonatal morbidity as well as mortality. So, antenatal screening accomplishes both the goals by identifying pregnant women and their fetuses at high risk for adverse outcome and applying timely and appropriate diagnostic and therapeutic measures to alleviate the risk factors. So with this much of introduction, let's go to look at what is high-risk pregnancy. I would be talking on definitions and incidences, then high-risk factors, detecting high-risk pregnancy, and finally, detecting specific diseases like diabetes, preeclampsia, etc. So first things first, definition. What is high-risk pregnancy? The high-risk pregnancy is one which is complicated by factors that adversely affect the pregnancy outcome. It could be any factor. There could be generalized factors, family factors, past obstetric factors, in the present obstetric factors, any factor that will have an adverse effect on the pregnancy outcome. What is the incidence of high risk pregnancy? We must have an idea about it, isn't it, before we uh, learn about it. It is very high. 20 to 30% of pregnancies, almost one third of pregnancies are high risk pregnancies. And if you don't recognize and take timely action, good number of them will have complications. They account for 70 to 80% of perinatal mortality and morbidity. This 30% of high risk pregnancies account for almost 80% of perinatal mortality and morbidity. That's why it's very important to recognize them early and tackle them early. And 60% of primary cesarean sections arise from high risk pregnancies. So 60% of 30%, they will land up in primary cesarean sections. That's why we need to understand this very carefully. What is a risk factor? Any ascertainable characteristic that is associated with the risk of either developing or being adversely affected by a morbid disease. So risk factor is nothing but a sort of disease which will have characteristics that is associated with the risk of developing or being adversely affected, right? So that is a risk factor. So now let's go to risk factors category wise. I have divided them into different categories like this. First one is universal risk factors. This is there for all populations anywhere in the world, irrespective of ethnicity, caste, race, religion, or whatever it is. And they are maternal age. So everybody ages, isn't it? So extremes of age, less than 19, teenage pregnancy is a risk factor. Simple as that. Even uh, a health worker who has no idea about MBBS or anything, she has just maybe 10th standard, but she can recognize the age of the patient, isn't it? So anybody who is teenager or anybody more than 35, she has to simply refer to a higher center. It is so simple. That's what is meant by universal risk factors, which can be identified by even the lady herself. Parity, primi gravida and grand multi. Again, extremes of parity. Primi gravida, we know, is high risk because of so many reasons, many problems like preeclampsia and preterm labor, difficulty in delivery, CPD. These are all very common in primi gravida. Again, in grand multi, the problems like transverse lie, postpartum hemorrhage, and malpresentations. These are very common in grand multi. Regarding the age, I forgot to mention teenage pregnancy has got all sorts of problems. Their pelvis is not well developed. Psychologically, she's not ready to become pregnant. There will be anemia. There will be preeclampsia. So there will be abortions. There will be preterm labor. So all problems are there in teenage pregnancy. Same goes true with more than 35 years. In addition to whatever I mentioned, probably there will be congenital anomalies. Down syndrome is very high, more than 1 in 355 or 350 is the incidence of Down syndrome. Gametes are not all right. So there will be chances of abortions in extremes of age group. Pre-pregnancy weight, less than 40 kg, more than 90 kg. Again, less than 40 kg is a recipe for FGR and more than 90 is a recipe for diabetes. So you should be in an optimum weight. Height, of course, short stature is a sure case of small pelvis or a contracted pelvis, which will definitely give rise to CPD. So what is short stature? In Indian scenario, it is anything less than 145 centimeters. Maybe abroad, they will take anything less than 5 feet. So anything less than 145 is a short stature. Social class, of course, this is the class which is battered like anything by all the sorts of problems and diseases, low socioeconomic status. So that is universal factors. Now, let me come to the factors which are based on previous reproductive history. So we need to take a detailed history regarding the previous obstetrics. Prolonged period of infertility. You know that if there is a prolonged period of infertility means you can anticipate PCOS in them, you can anticipate other problems that is giving rise to infertility, which will definitely have a bearing in the current pregnancy. PCOS ladies are having insulin resistance, so they may run the risk of abortions, they may run the risk of diabetes, and all sorts of dyslipidemia and problems like that. So infertility. Recurrent abortions, I have just taken last week the all sorts of problems that can be there in a patient of RPL, recurrent abortions. So they will definitely become a high-risk pregnancy because whole lot of issues will be there in them. Bad obstetric history. Now, what is bad obstetric history? In simple words, earlier we used to say 2 abortions, 1 IUD, or 1 IUD and other problems. But nowadays there is no need to mention any number because as it is, the women are going to have less number of children. So I would define bad obstetric history as any loss, whether abortion or IUD, and any means any number also. So any loss in the past that has an adverse effect on the present pregnancy outcome. So it could be intrauterine problems like abortion, IUD, and other things, or neonatal death also, because neonatal death, which the death that is occurring within 7 days, is called perinatal death after 28 days, of course, whereas obstetrics is responsible for the death of the fetus. So that's why it becomes a bad obstetric history. Congenital anomalies. We know that congenital anomalies sometimes they can repeat. Some are standalone, some are repeat anomalies. That's why we should be very careful, especially if the parents have any chromosomal problems that will repeat by itself, or if the patient is diabetic, let's say, and not controlled, the anomalies are going to repeat. Premature labor, 25% of the preterm labor is unknown, and only the previous preterm labor is the history that is available for us, and we have to be very careful, that to be vigilant towards that particular period of labor in the past. Difficult delivery or instrumented delivery, which automatically means that either there was some problem with the pelvis or there is some problem with the patient's uterine anomalies may be there, or her power generally. So if there was a difficult delivery last time, you may anticipate similar situation in this time as well. and every time the baby is going to become bigger and bigger. So if there was a shoulder dystocia last time, that means there was a problem, and this time it may repeat. Continuing with the previous reproductive history, cesarean section, a whole lot of indications for cesarean sections. Most of them can repeat, some of them won't repeat, of course. I am not going to say once a cesarean section is always a cesarean section. Otherwise, there won't be a chapter called VBAC or TOLAC, whatever. But we know that if there was a section in the past, this patient automatically becomes high risk this time. If not anything, there's a good chance of this patient having rupture uterus, silent rupture either in the antenatal period or rupture during labor. Even if you give VBAC, there could be always a problem or risk. So it becomes a high risk patient. In other words, just I'll pause and say, what is high risk? High risk is a patient in management perspective. These patients cannot be managed in primary healthcare center or secondary healthcare centers. These patients should be managed in a tertiary care health center. That is the meaning of high risk. They cannot have home deliveries, that is anywhere ruled out, not even primary healthcare centers. They should be managed mostly in the tertiary care health center. That is the meaning, in other meaning of high risk pregnancy. Third stage complications. Suppose the patient had either a postpartum hemorrhage or inversion of uterus or even rupture of the uterus or cervical tears. These patients will definitely may have repeat problems this time. Preeclampsia, eclampsia, and GDM. We know 25% of preeclampsia can repeat itself. Though it is a problem of primary gravida, there's a good chance that the person, elderly person especially, having dyslipidemia and either renal diseases or chronic hypertension run the risk of repeat preeclampsia in the current pregnancy. Same story goes for GDM. Birth weight of previous baby less than 2.5 kg or more than 4 kg. Again, as I said, anybody having a tendency for FGR or small for gestation, or anybody having a tendency for big baby, maybe the lady is obese, she has never bothered to lose the weight, or she is a known case of diabetes, so hypertension. So these are the patients who will have problems every time they become pregnant. RH isomerization or ABO incompatibility. Yes, we know unless we give the prophylaxis for them, they run a risk of having isoimmunized baby with fetal height drops and jaundice, etc. Okay, so we finished with the universal factors. We finished with the previous pregnancy factors. Now we have to look for the factors in the current pregnancy, whether there are any factors in the current pregnancy at all. So the factors in the current pregnancy could be history of pain or bleeding anytime, especially in the first trimester or second trimester, which suggests that there could be a problem with, retroplacental clot. There could be placenta low-lying or placenta previa, or pain could be suggesting of a threatened abortion, which runs a risk of later the preterm labor, or this patient may be a case of any anomalies in the uterus or with the baby. So history of pain and bleeding anytime in this pregnancy is a risk factor. Poor or excessive weight gain. Poor weight gain suggests that she is running for FGR, or excessive weight gain means she will run a risk of diabetes. So automatically she becomes high risk. Again, these two problems anybody can note down. If you give a checklist to an ordinary health worker, they can just tick, 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 and then they can refer to the higher center. So it is so simple, but unless you think of this, you will not be able to list it. If a question comes for 10 marks, you need to write all these factors in a very systematic way. Universal factors, previous pregnancy factors, 2 slides, remember, and present pregnancy factors and labor factors. All these things you have to nicely write. Medical diseases, of course, this can be easily made out by anybody. Just check a BP. It shall be a case of hypertension, hypertensive disorders of pregnancy. Check the sugars, diabetes. That's why we have to do all these things. Heart disease, just put in, just a stethoscope. You will know the murmurs, diastolic murmurs, especially respiratory problems. It is very visible to anybody. Renal problems, patient will tell about it. Hepatic problems, anemia. No, these and pyrexia, these are very simple, easily detectable problems. You don't need a big gynae specialist for detecting all these things, right? So multiple pregnancy. straight away runs the risk. Yesterday, other day, I was talking about multiple pregnancy. I told you all problems on earth will be there in multiple pregnancy, except, of course, postnatism and macrosomia. Other than that, entire obstetric book will be there in multiple pregnancy. So they are automatically high risk pregnancy. IUGR or FGR, whatever you want to call it, and macrosomia. I have told it in a different way in the previous slide. Anybody less than 2.5 kg, anybody more than 5 or 4 kg. So that's the same thing. But the only difference between previous slide and this slide is that I'm talking about current pregnancy. In current pregnancy, if you see that looking at the charts of the ultrasound, if the baby is lagging behind its own chart, or if the baby is going across 95th percentile, or if the fundal height is increasing enormously, then also you can suspect these things and it is a high risk pregnancy. Some more factors. See, I'm going through first trimester, second trimester, third trimester. This is the style that you have to go. Pre-pregnancy, pregnancy, pregnancy, first trimester, second and third trimester, labor, labor, first stage, second stage, third stage, and then postnatal. So you won't miss anything. So I have come to the third trimester problems like PROM, preterm labor in this pregnancy. So, preterm PROM can run a risk of preterm labor. Preterm labor runs a risk of extremely small babies which are prone for cerebral palsy, and there can be precipitate labor, postpartum hemorrhage, whole lot of problems. APH, whether it is abruption or placenta previa, it's a very, very high risk pregnancy. This cannot be admitted in a primary or secondary health care center. You need a lot of blood transfusions. One of the A in management of abruption is active management. You have to give adequate blood transfusion, ARM, and deliver. Placenta previa also requires a lot of blood transfusion. They should be, in fact, sometimes kept all the time in the tertiary care hospital. Oligo and polyhydramnios, again, they indirectly suggest about the FGR and or diabetes in the current pregnancy. Both of them require full attention at the tertiary care center. Malpresentation, of course, breech, most of the time you land up in doing cesarean section. And not only that, breech is indirect evidence of some anomalies in the uterus, some anomalies in the fetus, and some problems there. Placenta previa also may be the cause. So, once you are in the final year, once you are at this stage, everything should come. See how I'm without thinking, I'm just blurting out things, The breach means, you have to think of what are the causes of breach. What are the causes of breach? Again, they are all high risk factors, right? So transverse lie, same story. Placenta previa may be the case. Maybe she is a grand multi. Maybe she is having a anomalous arcuate uterus. See? So it just should come out. One word should just reveal everything to you at this stage of your career. Suspicion of CPD and abnormal pelvis. Yes. Even if the previous delivery was a normal delivery, it's no guarantee because, as I said, pelvis remains the same or it becomes rigid as the age advances, but the baby becomes bigger and bigger. So even though there was no CPD last time, there could be a CPD this time. Now, the only problem is the CPD assessment will be as late as early labor. Abnormal pelvis, that will remain all the time, isn't it? Prolonged pregnancy. Yes, last time there was no problem, but this time somehow the baby, the pregnancy is going beyond EDD. You should suspect maybe is there a big baby or if there is any other problem, transverse lie or something like that. So that is a thing. Now, factors due to previous surgeries. We have done with universal factors, number 1. Number 2, previous pregnancy. Number 3, current pregnancy. Now I'm going beyond obstetrics. That is previous surgeries. They also affect. Of course, the most important surgery that in obstetrics that we ask for is the previous cesarean section. And I've talked enough about previous cesarean section. Whole lot of complications can be there due to previous cesarean section. There could be placenta previa, there could be placenta accreta, in addition to rupture risk and other problems, right? So previous cesarean section cannot be dealt at all in even secondary care hospital. Laparotomy for any reason. You don't know why the laparotomy was done. Maybe it was a rupture uterus also, right? So you should know that about it. Fothergill's operation will run a risk of, incompetent cervix. Fothergill's operation nowadays very rarely done because we don't see that much of congenital elongation of cervix. I have hardly done a handful of surgeries of Fothergill's. But anyway, if there is a history of that, or trachelectomy, maybe other thing that is done these days is conservative surgery for cancer cervix. Repair of vesicovaginal fistula. Again, nowadays the vesicovaginal fistula as such has come down because of the better management of obstructed labor. But if it was there, then it is a high-risk pregnancy because you cannot allow vaginal delivery in these patients. They have to have elective cesarean section, especially high incision. Repair of complete perineal tear. These are the patients you have to think twice before giving vaginal delivery. Suppose it was there. Repair of stress incontinence. Again, you don't want to disturb the tape or whatever TVT, whatever you have put. So better an active cesarean section. So after dealing with the four types of risk, that is universal risk, the previous pregnancy risk, current pregnancy risk, previous surgery risk, now I come to other risk factors. What are these other risk factors? Okay, these are lifestyle factors. Don't think that smoking is only done by men. In fact, now men have stopped smoking, especially among the youth. I have seen that it is old-fashioned if the men smoke. So women smoke not only in the affluent places, but also you see this is a village lady who is smoking, and chewing tobacco is not at all uncommon. So these two are very risk factors. Alcohol and drugs. This has become very fashionable, socially accepted in the current life. So this will also have a risk in terms of, the babies will have FGR, babies will have alcohol syndromes, and smoking is generally not good. It will increase RPL, it will increase preeclampsia, it will increase, in name a thing, all the problems will be there. So they are definitely no. Sedentary lifestyle, this is a new addiction. Sugar is a new addiction, which all of us are trapped with. Fast food is a new addiction. Popcorn is a new addiction, right? So and just watching TV or just using mobile and having a sedentary lifestyle, which is bad. Heavy work, on the other hand, is also bad. If sedentary is bad, heavy work. Nowadays, most of the ladies are career oriented. All working women have to work at home also. So as you can see, she's doing kitchen work, she's cleaning, she's doing laundry, she's doing shopping, and she works at the office as well. Occupation, farmers run the risk of, the hookworm infestation if they work barefoot in the farms, and they will run a risk of anemia. Anesthesiologists run a risk of, FGR because they will be inhaling all sorts of fumes and other things. Neoplasms and malignancies, not uncommon nowadays. So if they are present during pregnancy, we will be in a dilemma whether to abort, whether to go ahead, whether or when to give chemotherapy, whether to deliver them early. So a whole lot of risk factors are there. So let me take a breath. It was almost like a breathless list of the factors, high risk factors. Now let us look at how do we detect high risk pregnancy. Once you know what is high risk pregnancy, detecting them is not at all a big task. We can just list the same list. We can keep on adding what investigations to be done for that. Regular antenatal checkup goes without saying. And what do you mean by regular antenatal checkup? This is a very basic question. I have seen many postgraduates getting stuck with this question, and examiners commenting, if you don't know regular antenatal checkup, you don't deserve to pass MD exam. You know everything. You know fetal anomalies. You know fetal medicine. You know reproductive medicine. You know urogynecology. You know a whole lot of things in gynecology, but it is of no use unless you know obstetrics, unless you know what is regular antenatal checkup, unless you know how to detect high-risk pregnancies, because obstetrics is chunk. Even if you're an infertility specialist, your basic bread and butter is from the obstetrics, right? And obstetrics is unique. There is nobody will deal with obstetrics, no physician, no surgeon, nothing. Surgeon may do a hysterectomy, but he is scared of pregnancy. He is scared of cesarean section. He is scared of delivery. So we need to know everything about regular antenatal checkup and routine investigations. I have seen one postgraduate failing for not knowing what is routine antenatal checkup. Or routine antenatal investigation, you would have ticked thousands of time in 3 years of course. But on the day of examination, she could not tell everything. So she has failed. Once in 4 weeks till 28 weeks. This is what I'm talking about, is the ideal antenatal checkup. So once in 4 weeks till 28 weeks, that is, or once in a month till 7 months, whatever we say. Then once in 2 weeks between 28 to 36 weeks. So first one is 7 visits. The next one is 4 visits. Then every week thereafter, that is another 4 visits. Totally 15 visits, 7 plus 4 plus 4. This is the most ideal. As you can see, the frequency increases as the pregnancy advances. This is very, very obvious and very, very commonsensical. I always tell undergraduates there are two general formulas in obstetrics. Number one is any problem due to pregnancy will show up after 20 weeks. That is one. Second general formula, any problem which was due to pregnancy will worsen, right, as the pregnancy advances. I may add third general formula. Right now, I'm thinking of it. Is that, of course, it was always there. The third general formula is any problem due to pregnancy should be I mean, the ultimate treatment is delivery only. So three general formulas. One is any problem due to pregnancy will show up after 20 weeks because it needs 20 weeks cooking time. That's what I call it. Second one is all pregnancy problems due to pregnancy will worsen as the pregnancy advances. And finally, the only solution is delivery. So keeping that in mind, as you can see here, once she crosses almost 28 weeks, enters third trimester, the visits become frequent once in 2 weeks. And in the last month, which is a very crucial month when you have to take decisions about delivery, whether she can go for secondary center, tertiary care center, or whether you have to do any other type of deliveries, early deliveries, you can wait till 40 weeks. All these decisions are made in the last month. So last month, she has to come every week. So this is one thing. Second one is booked case. Again, many students cannot answer what is booked case. Booked case is one, there should be minimum 3 visits. Now, these 3 visits cannot be first month, second month, third month, because whole lot of problems occur after half of pregnancy and they keep worsening. And the last month is crucial. So that's why it is said last one should be within a month of EDD. Otherwise, she has never come to you at all, even if she has come to you. I hope I'm clear. 3 visits, all right. But it is ideally, be 1 visit in first trimester, 1 visit in second trimester, and 1 visit at least within a month. That is a booked case in your center. She may have gone to other centers, but that's different. So booked case is 3 visits. Then, of course, there are other community visits. There are 4 visits. They say 1 in first trimester, 1 in second trimester, 2 in third trimester, or 5 visits earlier when I was a undergraduate, 2 in first trimester, 2 in second trimester, or 1 in third trimester, or vice versa, 1 in first trimester, 2 in second trimester, and 2 in third trimester. So whatever it is, ideal is 50. Now, what are the routine investigation? This is the $1,000,000 slide. This is a $1,000,000 slide. If you don't answer, you will have to shell out $1,000,000 to pass. If you answer, you won't get anything, right? So blood group and type is the most important single test. It is very important to pick up, first of all, to know whether she's a negative or positive. Secondly, you should know what is her blood group and type well in hand, because obstetrics is a bloody subject full of blood, right? Starting from the early and abortions, then the antepartum hemorrhage, postpartum hemorrhage. Every time you need blood group and type ready to transfuse the patient. HbPCV, anemia is so important, and it should be done 4 times actually. First trimester, second trimester, twice in third trimester. PCV is, of course, its accompaniment. Urine, the microscopy, albumin, sugar, and microscopy should be done at least once in each trimester. And then the serological test, HIV, HbSAg, and VDRL goes without saying. And these are all done right in the beginning. Now, to add to this, in Manipal, we do either FBS, glyco-HB, or RBS, either of them, not all of them, right? If you know already what is the status of the patient before becoming pregnant, you can straight away simply do glyco-HB. Or if you suspect she's a high risk, you can straight away do GTT as well. That doesn't come under routine, but GTT is for high risk patient. TSH is become a routine investigations in all centers now. We have been doing it for a long, long time, and ideal TSH should be less than 2.5. GTT, as I said, is in high-risk patients. Urine culture sensitivity, at least once you have to do. Why you have to do urine culture? Because there is something called asymptomatic bacteriuria, which has got same effect as urinary tract infection. So unless you did a urine culture and sensitivity, you will never know about this asymptomatic bacteriuria, which is nothing but no symptoms, but the colonies are more than 10 to the power of 5. So this is usually done in the second trimester, 24 to 28 weeks. Fetal checklist for ultrasound. Now, without ultrasound, we cannot practice obstetrics, forget it. So what are the routine ones? Routine, I'm talking about 5 to 7 weeks. It's called early scan. This will not only confirm pregnancy, it will rule out ectopic, molar, and twins. This is a must. This will also tell you about the exact dating. Suppose you have done at around 8 weeks to 10 weeks. So it is called dating scan. Uh, this time you can even detect one anomaly in the first trimester, that is the anencephaly. 11 to 14 weeks has become a very important genetic scan. What we say NT has to be done. Along with that, you will do dual testing and if required, CVS also. 15 to 17 weeks is the time you would do a triple test. Nowadays, we don't do triple test at all. If you have missed the dual test, this is the time to do quadruple test. And if the dual test had shown high risk, you would do amniocentesis. This is the ideal time for amniocentesis. 18 to 24 weeks is the anomaly scan. Now that the court gives us permission to even abort up to 24 weeks in selected cases. Ideally, the anomaly scan earlier we used to say to be done between 18 to 20 weeks, but now because of this extension, echo is better appreciated after 20 weeks. So I've given a little bit of stretch 18 to 24 weeks, but ideally around 20 weeks. Because should there be any problems, it is easier to go for a second trimester MTP. 28 to 40 weeks. It's the serial growth scan time. Once in 2 weeks or sometimes 3 weeks is also okay. This is to find out the early FGR or early macrosomia, and later gestations, 32 weeks onwards, maybe sometimes weekly, to do the fetal well-being, BPP, or even Dopplers, depending upon the high risk factor. So dating scan is very important, and genetic scan is important, anomaly scan is important. All others are also important, but these three are a must. Serial growth scan. So I'll just show quickly some of the pictures that you can see. Early gestational sac, what you can see, and a twin sac. And here is a fetal pole and a yolk sac. Yolk sac should not be big or it should not be remaining after 9 weeks. Fetal pole, you can easily make out the pulsations as well as early as 42 days. And the crown rump length is the best estimation of gestational age, done around 8 to 10 weeks. And then you have early BPD. BPD we know is erroneous. First trimester 1 week plus or minus, second trimester plus or minus 2 weeks, and third trimester plus or minus 3 weeks. And here is the nuchal translucency. That is the red line, what you can see. And of course, nuchal translucency from the other angle, that is the transverse. But the first picture is the best one. And of course, face profile, if you can see the nasal bone or this kind of a profile, you can almost rule out the Down syndrome. Face end-on view, you can see that the eyes and nose and mouth, everything can be seen. Cleft lip, cleft palate can be made out here. Facial structures are very, very clearly seen in this particular profile. And ear low, so much so low set ears, low set eyes will be a sign of Down syndrome. Again, BPD is the best plain arrow sign. That's what we have been talking about. There are so many other things now, but arrow sign is more than enough. Femur is a hockey stick pattern you have to see. Abdominal circumference, you have to see that portal vein and two holes there. Spine, you can make out spina bifida, any difficulties or any breach in the spine. And here is a four-chamber heart. There's much more than four-chamber now. For that, you have to listen to some fetal medicine lectures. I'm not a fetal medicine specialist. Hand, again, whether there are four fingers or 5 fingers, or whether it's a Hrithik Roshan with 6 digits, right? 3D face makes it much more clear, for us to detect anomalies. Hand also, this is very beautifully, tight fit, stiff person. And, leg and feet, everything you can make out these days. So I'll now come to the last leg of my talk, that is how to detect specific diseases. I have told about this in different lectures, but here is one area where you can get everything in one place. So first of all, predicting and screening for diabetes, the low risk factors is age itself is good enough, less than 25, normal weight before pregnancy, no family history of diabetes, no abnormal glucose, or no nothing. Whereas medium risk is she's 25 to 35, slightly overweight, diabetes in first degree relatives, and women of Asian or Hispanic origin. High risk is obviously after 35, marked obesity in herself, strong family history of diabetes, previous history of GDM in herself, and repeated glycosuria. So the screening is important because India is a moderate risk country. This question was asked once in DAB. Why do you have to go for universal screening? The answer is simple: moderate risk country. If it is low risk, no need of screening. If it is high risk, straight away diagnostic test. Only in moderate risk countries you do go for universal screening. And it consists of two phases. First phase is first trimester, which is practiced in Manipal, either HbA1c, which should be less than 5.9, or FBS, which should be less than 92, or RBS, which should be less than 200. They are not all to be done, either or. The phase two is second trimester. If you want to do one step, you can do that, or two step also you can do. One step which is practiced in Manipal is the IAD PST, International Association of Diabetes and Pregnancy Study Group, GTT. It is done between 24 to 28 weeks, 3 days of normal diet, overnight fasting, fasting blood sugar, 75 grams oral glucose tolerance test, and blood sugars at 1 hour and 2 hours. 1 hour should be less than 92, 2 hours should be less than 180, and 3 hours is 153. Cutoffs, as I said already, 92 is fasting, 180 is 1 hour, and 153 is 2 hour. Interpretation is any one abnormal value is considered as GTT. If negative, repeat at 28 to 32 weeks. Why? Because as the pregnancy advances, insulin resistance increases. As simple as that. If you believe in two-step, which we used to do in the past, a 50 grams OGCT, if abnormal, then you go for cutoff was 150, 140 at 1 hour. Detects 90% of diabetes, 15% will have positive GCT, and the second step is you can do a 75 grams GTT. Now here is Sheshaya's combined. This is promoted by Government of India as well. It's called DIPSI, Diabetes in Pregnancy Study Group of India. It is a simple test done again between 24 to 28. Here they have taken the advantage of all sides or both worlds. That is, the glucose given is 75 grams, not 50 grams, as in spot test. And the cutoff is 140, as in the spot test. But it is after 2 hours, not after 1 hour. So it's a smart test. So at least this one test should be done. Any time of the day is the advantage of it. Patient doesn't have to come fasting. And, 2 hours waiting in the clinic is not a big deal. So if it is positive, you have to go for sugar profile. If it is negative, it should be again repeated at 30 to 34 weeks. So as I said, this is the Government of India Universal Screening Program. It's the same thing what I said. What are the indications for GTT straight away in first trimester? I've already given you a clue. Elderly age group, all high-risk patients, family history of diabetes, obese woman, unexplained maternal weight gain or loss, past history of GDM, past history of congenital anomalies, past history of macrosomia, past history of or current history of PCOS, recurrent abortions, unexplained IUD, presently having twins, repeated cardiac infection, other indications. So all of them should have straight away GTT. 2 slides, remember that. FBS, again, if it is more than 92 or RBS is more than 200, we consider it as definitely a case where we need to at least give metformin. Diet and exercise goes without saying. You can, if you want, you can try in the earlier case, that is when it is FBS is more than 92 but less than 95, you can try 2 weeks of diet. But once the RBS is more than 200, it is better to start some medication. Sugar profile is like this. Fasting should be anywhere between 95 to 100. If you can remember only one number, 95 is the number. Whereas after 1 hour, it should be 140. But usually we do after 2 hours in pregnancy. Easy to remember, 2 hours means 120 minutes. The sugar should be 120. So that's why I've highlighted 95, 140, and 120. So rule of 15 in GDM is by Gabby is that 15% of positive GCT will have GDM, 15% of GDM will require insulin, 15% of GDM will have macrosomia, and 15% of GDM will have type 2 diabetes later in delivery, later in life, within 15 years. So I'm done with diabetes. That lets me come to prediction of screening for preeclampsia. This is very, very, very important. Unfortunately, we don't have a single predictive beautiful test like in diabetes. There are lots of theories, lot of problems, but the risk factors is very important. Nulliparity, preeclampsia and previous pregnancy, age, extremes again, family history of preeclampsia, chronic hypertension in her, chronic renal disease in her. In addition to that, autoimmune diseases, we all know about APLA syndrome and systemic lupus erythematosus giving rise to preeclampsia. Vascular diseases, diabetes and hypertension are close cousins. I have told this many, many times. Obesity, multifetal gestation, what we used to call earlier supranormal hypertension, hydrops vitalis, and poorly controlled hyperthyroidism. Not over, women herself was a small for gestational when she was in her mother's tummy. FGR abruptio fetal demise in a previous pregnancy in this lady. Interpregnancy interval increases the risk factor. If it is long, then if the previous pregnancy was normotensive. If it is short, if the previous pregnancy was preeclampsia. Partner related, if you change the partner because it's all with the first pregnancy with a new partner, that will have problems. The modern risk factors are IVF, obstructive sleep apnea, elevated blood lead levels. This is environmental hazard, post-traumatic stress disorders, and black race. So among them, if you want to filter, very high risk ones are the lady having previous pregnancy with preeclampsia, up to 25%, I told you already, especially early onset preeclampsia, it will have always adverse outcomes. Multifetal gestation in the current pregnancy, chronic hypertension, type 1 or 2 diabetes, renal disease, and autoimmune disease like APLA and systemic lupus. This is a very important slide. Remember this. Moderate risk is nulliparity, obesity, family history, age more than 35, socio-demographic factors, and personal risk factors. What are the tests you do with all that knowledge? So systematic reviews of studies that evaluated clinical available tests are generally concluded that these tests are not sufficiently accurate. Whether it is a rollover test, grip test, and angiotensin test, these are now almost obsolete. Right? So ACOG recommends very, very simple test. What is that? We are gone back to square one. Like old fashion comes as the new fashion. Now, this is the old thing, but it is the recent advance. What is that? Take a detailed medical history and assess blood pressure to evaluate the patient's risk for developing preeclampsia. Biomarkers, yes, angiogenic factors. You can either go for vascular endothelial growth factor, VEGF, placental growth factor, which we do in Manipal, PLGF, anti-angiogenic proteins like soluble endoglin, SENG, what we say, or soluble FML like tyrosine kinase, SFLT1. So women who developed preeclampsia, concentrations of placental growth factor and VEGF were lower, whereas concentration of SFLT1 and SENG were higher. So other tests like people have tried to do pregnancy-associated plasma protein, PAPA, because this is routinely done nowadays as a dual test. So if you do this, that will also give us a clue. Abnormalities in cell-free DNA levels also can be made out. Now, people have gone for uterine artery Doppler. We did this thesis long back, around maybe more than 25 years ago. But most experts do not recommend these studies of screening in early pregnancy as the false positive rates are quite high. We also felt the same thing. People have gone for all sorts of arteries, ophthalmic arteries. Nowadays, the other day I was other day saying Google is coming out with just an ocular scan to predict everything on Earth using artificial intelligence, but it has got little clinical utility. Detection rates of FMF London and fetal medicine Barcelona combined first trimester screening algorithms, they have got good range, the prediction range from 75 to 92%, and a false positive is only 10%. So this is what I said, we do it in Manipal. Along with the dual test, we send these extra information, decomatous markers like parity, race, previous preeclampsia, hypertension, blood pressure, especially the mean arterial pressure, biochemistry, we always anyway ask for PAP-A. We additionally ask for PLGF, and of course, ultrasound findings, especially the uterine artery Doppler. With all that, they give us a report which simply says whether there is a high risk or a low risk. So this is like 3-in-1 test. It will give us information about the risk factor for the Down syndrome. It will tell us about the risk factor for preeclampsia and additionally FGR. So this is the test nowadays we do, and this particular patient is like low risk. Not useful are other tests, like I already said, rollover test, angiotensin 2, and these are cumbersome. Luckily, we don't have to do serum uric acid. Also, is not very predictive. Screening for inherited thrombophilias is only in research settings. I told the same thing for RPL also. APS in general population is not required. Only in high risk population it is required. Screening for Down syndrome, we all know this very well. Advanced age itself will give us a clue. These are the indications for doing the dual test. Previous pregnancy with chromosomal abnormality, chromosome abnormality in either of the parents, fetus with structural abnormalities, and parental carrier of autosomal recessive disorders. So, plus parental carriers of autosomal recessive disorders, mother carrying X-linked disorders, maternal thyroid antibodies. What is the test? NT plus dual test. So dual test is HCG-PAPA. I have already explained that this has got additional benefit of predicting preeclampsia alone with the PAPA results. But if you add placental growth factor, this is much better with other factors. Quadruple test is done if you have missed the dual test. Triple test somehow we don't do at all anymore. Genetic scanning, that is NT. Targeted organ scanning can also be done. So this one gives us the different ideas how the different markers will affect the different risk factors. So you can do all these tests. This is a single screen which will give you everything. Take a screenshot of this. It's too much for me to explain, read everything. So please take a screenshot of this. I'm giving you enough time. Right? Okay. So indications for high resolution scan, positive dual test or quadruple test, so that you will look for the anomalies very nicely and clearly. Women that underwent CVS or amniocentesis, one more time you have to see properly when the baby has grown to 20 weeks. Family history of anomalies or chromosomal anomalies. Oligo and polyhydramnios, both are running a risk of anomalies. In the sense, oligo means there could be IUGR, which can be traced back to a fetal anomaly, intrinsic factor. Polyhydramnios can be traced back to diabetes, and again, diabetes means anomalies. Maternal diabetes, and these are all some of the indications. Other ones are malpresentations. As I told you, malpresentation can be because of the anomalies in the uterus as well as anomalies in the baby itself. So that is breech. Multiple gestation will again run a risk of a whole lot of problems, especially TTTS, TRAP syndrome, all those things you can make out. Exposed to potential teratogen in first trimester. And symmetrical IUGR, as I said, intrinsic factor. Suspicious findings at routine ultrasound. You have to go for a high resolution. These are some of the things which you can do by ultrasound. Korean villus sampling around 10 to 12 weeks. And Korean villus sampling can be done by TVS as well. Amniocentesis around 15 to 17 weeks by TAS. Chordocentesis, again, same thing. Screening for anemia, I don't have to tell you. To note the degree and grade of anemia, HB 4 times, PCB and RBS count. To note the type of anemia, peripheral smear indices, serum iron, SIBC, and serum ferritin. To know the cause of anemia, examination of urine, stool, or OVA cyst, fractional test meal, serum proteins, osmotic fragility test, and electrophoresis. And of course, very rarely, when she is not responding at all, bone marrow also, to rule out any suppression or malignancies. Blood values in iron deficiency anemia, HB it will be less than 11, PCV less than 30, serum iron less than 60, TIBC more than 300, ferritin less than 15, saturation less than 15, and peripheral smear shows microcytic hyperchromic. I have rounded all these figures for easy remembrance. It's like a table of 15. Use again make a ferritin 15. It's that rhyme also. Screening for heart disease, very simple. Patient will have symptoms, but you don't diagnose heart disease by symptoms alone. But that will give a clue. Chest pain, palpitations, breathlessness, syncope, progressive orthopnea, hematesis, and paroxysmal nocturnal dyspnea. If at all by symptom, this is the only symptom that can diagnose heart disease. Sign-wise, pathological edema, cyanosis, clubbing, persistent increased GVP, persistent split second sound, loud P2. But the diagnosis is made only by diastolic murmur. Diagnosis, diastolic. Diagnosis, diastolic. Remember this. Pansystolic murmur is okay, not a soft systolic or ejection systolic murmur. If at all, the systolic murmur should be associated with thrill. Cardiomegaly, not by your clinical examination, because as it is, the heart is pushed towards left in pregnancy. It should be diagnosed by echo and ECG. Finally, arrhythmia. Why I'm saying finally? Because by the stage she reaches arrhythmia, she's almost in the deathbed. We should not delay that diagnosis to that extent. Screening for FGR, I will be going to take a long class on FGR. Today, it is enough to show that these are the charts we should be depending upon and plot it. There are two types of plots we can see. Asymmetrical is late flattening and symmetrical is low profile. So these charts will give you idea. Some of the special investigation, thyroid stimulating hormone, TSH, we do this. It's not a special investigation anymore. Liver function test in the previous cases of preeclampsia, renal function test in the same situation, indirect Coombs test for Rh negative women, platelets, ATP, if there is any adult type of thrombocytopenia or preeclampsia. Torch, of course, has lost its torch light. We don't do it often nowadays. Danger signals during pregnancy. This is the checklist for the healthcare workers who are working in the field. The 10 danger signals. Number one is pain abdomen. Very simple. Bleeding PV, leaking PV, discharge PV, weight gain, static or excess, uterine height less or more, and then raised blood pressure, edema, headache, blurring vision, jaundice, and decreased urine output. This I have taken from Community Medicine book. Anemia, murmurs on auscultation, decreased fetal movements, short stature, mobile head at term and malpresentation, and prolonged pregnancy. Thank you so much. I hope it was very useful to you because you must know about detection of high-risk pregnancy, the routine investigations, and antenatal checkup. Otherwise, you will be in trouble. You will run a risk of failing in the exam. Thank you.